Uh, as I go through the slides, I see one of the highest incidence of fungal infection is in patients with acute lymphoblastic leukemia. And one of the problems in prophylaxis over there is if you use azole, there is an interaction with vincristine, which is the mainstay of therapy, and there is an interaction between vincristine and azoles. And if you use something like micafungin, you will not, it's an intravenous therapy, and you cannot do it with patient in the outpatient setting. So let me ask you, in each of your institution, how do you deal with it? And sometimes the toxicity is really bad if you're using azoles, that you have to stop their anti-ALL therapy, and that has effect in their outcomes.
That's an excellent question. In fact, that was something that we spent, I think, a good 10 minutes on before the actual symposium discussing about, because internally in our own ALL use, whether it's with hyper-CVAD in ALL or trying to use some of the earlier BFM regimens and AYAs, we struggle with this concept, and I don't know that there's definitely a right answer. I don't know if
I don't think there is a very good answer, and I will say that, for example, the NCCN guidelines suggest an echinocandin, and I know that's very burdensome for the patient. But we also try to avoid the azoles in that situation. There's not a great answer for that because of the severe neurotoxicity.